So hi guys, good morning. This is Dr. Singh from Mount Sinai. Today I'm going to talk about how do you approach Lichenoid Dermatitis. And I'm going to use the platform that we built for presentations called Path Presenter. Initially, I'll just show you how to use Path Presenter for a brief 10 minutes and then then move towards the actual presentation. So Path Presenter is a platform that we have built for self-learning of pathology, for teaching of pathology, for making any presentations in pathology and sharing cases actually. So these were problems that we always faced in pathology, and we tried to make a platform that could solve these problems. So how do you use it for self-learning? So when you go to pathpresenter.com, you register, and once you register, you can log in. And once you log in, you'll see this what we see here on the computer right now. So this is going to be a blank screen, and on the top you see the search library. So if you click on search library, and you get this, we have put around 6,000 slides on the cloud, which encompass the entire field of pathology. So skin, bone and soft tissue, head and neck, everything. So suppose you want to look up cases of bone and soft tissue. So you click on bone and soft tissue and you search, and it will pull out thousands of cases of bone and soft tissue. You can look at any. So when you click on display, it will actually pull up a slide, and then you can use the slide to look at the slide. So this is a desmoplastic small round blue cell tumor actually. So you can see that the slides is easily available to you once you log in, and you can then use the slide for learning actually. The slides are, you can move them around. So this is the rotation bar. When you want to bring it back, you click on this. These are annotation bars. If you want to go by specific diagnosis, you just put in a diagnosis. So say I'm looking for a case of psoriasis. So if I put in psoriasis and then search, it will pull out multiple cases of psoriasis. So if you click on display, you'll be able to see a slide of psoriasis actually. And you can zoom in, zoom out. You can take pictures, whatever you need for your presentation. So that is how you use it for self-learning. Now, if you want to use this for making a presentation, so you click on new presentation, and then you give it a name, like whatever name you like, PP Path Presenter 1, and then you create. So once you've done this, then either you can just make a presentation that is only digital slides, or you can make a presentation that has both digital slides and a PowerPoint. So if you want to make a presentation just say of digital slides, like yesterday when I wanted to teach the residents say a topic on paniculitis, so I go to import from library, and then if I start typing paniculitis in the diagnosis, it will pull out a lot of cases on paniculitis. So if lupus paniculitis, search, it'll pull out a case. You look at the case. If you like it, you add it to the presentation, and then you give it a number, slide 1, save ad, reset. Then you go back to paniculitis, search. You look at the slide. If you like it, then you add it to the presentation. So this way you can add multiple slides to your presentation. So then when you go back to your presentation, the slides will be in your presentation, and you can then look at the slides actually. If you want to import a PowerPoint, you just click on import PowerPoint. You browse your computer or your hard drive. And you can click on any PowerPoint, and then I'm just trying to find a smaller one. And you can import the PowerPoint into your presentation. So it'll take around 2 minutes to import the PowerPoint into your presentation. Once you have the PowerPoint in your presentation, you can then drag and drop the slides to make the presentation. How do you share a case? So once you have either you can upload a digital slide. You can use the upload digital slide on this where you see the upload digital slide, and then you can put in the browse your computer and upload the slide. And once your slide is there, so your slide will come up here, and then you just click on this arrow. You put in the email address and click enter, and the person will get an email within 3 minutes that that the person wants to share a slide with you. So like once you make a presentation, how does it look actually? So this is the presentation that I made for today. So this was the presentation. So there's a PowerPoint here, and there are additional digital slides. So you can drag and drop these slides as you like. So you can drag and drop them to make to arrange in the way you would like to present them. And once they're all done, you can then start your presentation. If you want to like annotate a slide, you just look at the slide. If you want to show this, so this is the add annotation button. You add the annotation, and you can say lichenoid inflammation, and you save it, and it will save. So when you want to see the annotation, you click here. You click here, and it will show the annotation. And when you drag your arrow upon the annotation, it will show what you have written there actually. So let's start the presentation. So that will give you how the presentation would actually look. So once you open up your presentation, so this was the presentation that we made. So you click on launch presentation. And this is the full screen button that you see here on the second last button here. You click on that, and then you just start your presentation. So let's start on the presentation approach to lichenoid dermatitis. So I always like dermatopathology is a very algorithmic approach. So you always have to approach dermatopathology in a very algorithmic fashion, and that is how I always try to teach my residents. So where is the main action in a lichenoid reaction pattern? It is at the dermal epidermal junction. So the dermal epidermal junction is the key zone of pathological changes for many skin diseases that include the interface dermatitis. So what happens when there is damage to the basal keratinocytes at the dermal epidermal junction? It leads to intercellular edema, blebbing and separation of the basal keratinocytes. You can have a lichenoid infiltrate which can vary from very dense to very mild. You'll see some necrotic keratinocytes because the keratinocytes are being attacked by the lymphocytes, and definitely there's going to be basement membrane alterations. So all these findings are histologically summed up as interface dermatitis. So this is the reaction pattern that we call it as an interface dermatitis. And interface dermatitis encompasses two reaction patterns. One is a lichenoid dermatitis, and the other is a vacuolar dermatitis. In the lichenoid dermatitis, you see a dense lichenoid infiltrate hugging the dermal epidermal junction. And that is different from a superficial perivascular lymphocytic infiltrate where the inflammation is more confined around the superficial vessels. In the vacuolar dermatitis, you're going to see some mild lymphocytic infiltrate, but the main changes is the vacuoles that you see that are develop at the dermal epidermal junction. Today, we are going to focus on lichenoid dermatitis. So when you're looking at lichenoid dermatitis, how do you approach what is the algorithmic approach for lichenoid dermatitis? So you want to look at what is the degree of inflammation? Is it moderate to dense? Is it mild to moderate? Or is it associated with a deep involvement? So either it is not associated with deep or it is associated with a deep involvement. So we are going as an algorithm. So once you say it is a moderate to dense inflammation, then the next thing that you want to ask yourself is there any parakeratosis or no parakeratosis? The next question that you ask yourself is, are there any eosinophils present in the infiltrate or are there no eosinophils? And then you look at the history, is it a multiple lesions or single lesion? So once you have decided that this is a multiple lesions, there are no eosinophils, there are no parakeratosis, then your differential diagnosis is going to be different. So you just have to first decide multiple lesions, is it single or is it multiple? Is there any parakeratosis? Is there any eosinophils? And what is the degree of inflammation? So if it is multiple lesions, what is your differential diagnosis? The differential diagnosis for multiple lesions and usually no parakeratosis is the prototypical lesion is lichen planus. But then the other thing that you have to think of is hypertrophic lupus erythematosus, lichenoid graft versus host disease, and if there is a subepidermal split, you have to think of lichen planus pemphigoides. So what is lichen planus? So clinically, lichen planus presents as pruritic polygonal erythematous to violaceous flat-topped papules, more common on the extremities and the genitalia. Commonly, you're going to have some nail dystrophy. So what do you mean by nail dystrophy? There is linear ridging. There is longitudinal ridging. You might have some splitting of the hair of the nails, and then sometimes, and very classically, many times you'll see pterygium formation. Oral lesions are very common in lichen planus, and you often see the Wickham striae, that is the white lines, not only in the oral lesion but also on the skin lesions actually. And when you look at a slide of the lichen planus, what do you see? So this is actually a digital slide. So when you zoom into a slide of lichen planus, like I said, it's a lichenoid infiltrate. So it's a dense lichenoid infiltrate at the dermal epidermal junction that is hugging the dermal epidermal junction. If you start from the top, you usually see hyperkeratosis, no parakeratosis as you see here. You see this wedge-shaped hypergranulosis, dense lichenoid infiltrate, and then scattered colloid bodies. So what do you mean by colloid bodies? Are these pink keratinocytes that have lost their nucleus. So some people call them colloid bodies, some people call them Civate bodies. They all mean the same thing. They are mostly dyskeratotic keratinocytes that have lost their nucleus actually. So again, if you go low power, what is the main thing that you see here? Hyperkeratosis, wedge-shaped hypergranulosis, a dense lichenoid infiltrate, and Civate bodies or colloid bodies at the dermal epidermal junction. So whenever you see like a lichenoid infiltrate, what is the next thing you need to do is you need to go high power and then go and scan the entire dermal epidermal junction to look for eosinophils. Do I see any eosinophils? So because lichen planus mostly will never show any eosinophils. So you don't want to see any eosinophils in lichen planus. So if you don't see any eosinophils, then and if the lesions are multiple, then your diagnosis is going to be lichenoid dermatitis compatible with lichen planus. And there are multiple variants of lichen planus that you'll come across, but the most common variant that you're going to see is the hypertrophic lichen planus. And hypertrophic lichen planus commonly presents on the lower extremities of African Americans. The most common location is the shin. So they are most commonly on the shin of African American patients, and the lesions tend to be much larger than what you would normally see in a regular lichen planus. When you look at the histology, so here's a slide of hypertrophic lichen planus. Again, you see the dense lichenoid infiltrate there at the dermal epidermal junction. But as the name suggests, hypertrophic. So the epidermis is quite hypertrophic. Again, you don't see much parakeratosis on the top, but many cases of hypertrophic lichen planus may sometimes show parakeratosis. So hyperkeratosis, again, you see the wedge-shaped hypergranulosis. The epidermis is quite hypertrophic or acanthotic. And then you see the lichenoid infiltrate. And then when you go high power, you're going to see the Civate bodies or the colloid bodies, what you would want to call them. The main differential diagnosis for hypertrophic lichen planus is a squamous cell carcinoma. So you have to make sure that there is not too much of atypia, because you have to always think of squamous cell carcinoma. And many times the reverse happens. It is the squamous cell carcinoma. The main thing that should go through your mind is, am I looking at a case of hypertrophic lichen planus? Because that is your main differential diagnosis. You don't want to give a diagnosis of malignancy to a patient who has lichen planus actually. So whenever you're thinking of squamous cell carcinoma on the lower extremities, always think of hypertrophic lichen planus. So once you think of it, you're going to try to see the features. So what the mind doesn't know, the eyes are not going to see. So if your mind knows that I have to think of hypertrophic lichen planus, then you are going to go down and look for the lichenoid infiltrate, the Civate bodies, and if you see them, then you say, oh, this is not squamous cell carcinoma, this is hypertrophic lichen planus actually. When you do immunofluorescence on lichen planus, you're going to see colloid bodies that are highlighted with the Ig, M, and C3 many times, and this can be on your board. So what do you see on immunofluorescence on lichen planus? you're going to see colloid bodies that are highlighted by IgM and C3. How would hypertrophic lupus erythematosus look? So clinically, they present with verrucous hyperkeratotic plaques, mostly on the face and the scalp, and sometimes they will involve the extremities, but more common on the face and the scalp. When you look at a slide of hypertrophic lichen planus, again you see a lichenoid infiltrate that is hugging the dermal epidermal junction. So you can see the lichenoid infiltrate, but what is different from the other cases that we saw of lichen planus? This infiltrate also tends to go a little bit deeper, and it is also peri-ecrine actually. So when you start seeing a lichenoid infiltrate that is hugging the dermal epidermal junction and some inflammation going into the deeper part of the dermis, you also have to think of, could this be lupus erythematosus actually? And many times in the hypertrophic variant, you might not even see the deep infiltrate. All you're going to see is this acanthotic epidermis and then the dense lichenoid infiltrate. And the only way to differentiate at that point would be do an immunofluorescence, because in the lupus erythematosus, you're going to see a full house. So you're going to see IgG, IgM, C3 and everything at the dermal epidermal junction, whereas in lichen planus or the immunofluorescence is going to be negative actually. And lichenoid graft versus host disease is one of the variants of the chronic graft versus host disease. So graft versus host disease can be acute and can be chronic. So in the chronic, there are two variants. One is the lichenoid variant and the other is the sclerodermoid variant. So these tend to present similarly to lichen planus, but they are more generalized and may involve the mucosa actually. So what do we see on histology? So like for acute graft versus host disease, the main feature that we are always looking for is diskeratotic cells in the epidermis. So here you can see there is somewhat of a lichenoid infiltrate at the dermal epidermal junction, but then there are scattered diskeratotic cells that you find at the dermal epidermal junction. And when we are looking for, even in the acute phase of graft versus host disease, the main thing that you're always looking for is the presence of diskeratotic cells. And if you see a hair follicle, you are also going to find diskeratotic cells in the hair follicle. So that would also be in your differential of a lichenoid infiltrate, that this could be a lichenoid graft versus host disease. In lichen planus pemphigoides, like I said, you will see, so mostly clinically they tend to involve the extremities, not the oral mucosa. The oral mucosa is rarely involved, but I had a picture of the oral lesion, so I put the picture. But remember, in lichen planus pemphigoides, it tends to occur. So like the name suggests, it is a combination of lichen planus and bullous pemphigoid. Bullous pemphigoid occurs in older people. Lichen planus pemphigoides tends to occur in much younger people actually. It can even occur in children. The blisters occur in the background of lichen planus and they are usually on the extremities. Oral lesions can occur, but they are much rare as compared to bullous pemphigoid. But like the name suggests, you're going to see a split. So let's rotate this slide. So what you again see is a lichenoid infiltrate at the dermal epidermal junction with a subepidermal split. So when you see a subepidermal split with a lichenoid infiltrate, a differential diagnosis is lichen planus, which is bullous, or a lichen planus pemphigoides. And how do you differentiate between the two? Like one is the histology. In lichen planus pemphigoides, you are going to see more neutrophils and eosinophils admixed within the infiltrate. And in bullous lichen planus, you're only going to see lymphocytes actually. And the main way to differentiate between the two is going to be immunofluorescence. So if it is lichen planus pemphigoides, you're going to have linear IgG at the dermal epidermal junction. And in bullous lichen planus, you're not going to see the linear IgG at the dermal epidermal junction. So if I look around, I'm going to find some eosinophils or neutrophils in the infiltrate actually. So here's a eosinophil here, and when you want to like show this in a presentation, like you can mark this before. So what I did is I marked. So I use this use annotation toolbar to mark it, and now I can just click on this view annotation, and when I click on the annotation, it will show the eosinophil actually. And then when you zoom here, it will actually show what you wrote for the eosinophil. So you can also use this tool to highlight features that you would want to show in a presentation actually. So the annotation tool helps in highlighting features that you want to show in a presentation. So now we'll move on to, so that was all the multiple lesions. So if you have, if it is a single lesion that shows a lichenoid infiltrate, what is your differential diagnosis? So either it is a lichen planus like keratosis, it could be lichenoid actinic keratosis, or it could be a regressing lentigo maligna.
I have a question, Dr. Singh. So regarding like just, it's a very basic, regarding the oral lesions. So oral lesions, you often see those Wickham stria,
Yep,
right?
yeah.
So do they have a different histology, or it is the same like what you see in the extremities?
It's mostly the same. The only difference, like many times you're going to see, you're not going to see the wedge-shaped hypergranulosis, because in the oral cavity, the granular layer is not that prominent actually. But you're definitely going to see the dense lichenoid infiltrate and the colloid bodies even in the oral lesions.
So the Wickham stria, when you see those, if you take a section from the Wickham
You're
stria,
still going to see the lichenoid infiltrate, yep, because that is part of the lesion actually. And that is what is causing the white lines, because it's some sort of a depigmentation. Because many times in lichen planus, you're also going to see melanin in pigment incontinence in the dermis, and that is causing the depigmentation, and that is the white streaks that you're seeing in lesions of lichen planus. So in a lichen planus like keratosis, it looks almost. So when you look at it clinically, now it's a single lesion, so it's not a rash. So that is a very important feature to always look out for basically. So if you see something that looks like lichen planus, you always have to look at your requisition. Is it a single lesion or is it multiple lesions? So many times it will come in as rule out BCC, rule out actinic keratosis. So then you know that the clinician is just looking at a single lesion. He's not looking at a rash. But if that is not mentioned, you have to pick up the phone and talk to your clinician. Is it a single lesion or multiple lesions? But many times the history will tell you, because it will say rule out BCC, rule out AK. So then you know that is a single lesion actually. So these are usually single lesions present with like violaceous brown papule, usually very common on the upper chest. So most like 90% of the times it will be a lesion on the upper chest. Middle-aged female comes in as rule out basal cell carcinoma. And then when you look at the histology, so this is the histology of a lichen planus like keratosis. So again, it looks very similar, but now these tend to have some sort of parakeratosis on the top. Although this slide doesn't show you very good parakeratosis, but most cases of lichen planus like keratosis are going to show you parakeratosis on the top, and then the same features: the hypergranulosis, the lichenoid infiltrate at the dermal epidermal junction, and presence of colloid body. So you can see the presence of these colloid bodies here actually, and the pigment incontinence in the dermis. So colloid bodies, pigment incontinence in the dermis, and the lichenoid infiltrate at the dermal epidermal junction. So if it is a single lesion, it is lichen planus like keratosis. If it is a rash, then it is lichen planus. In the lichenoid actinic keratosis, these are usually single lesions again. But when you look at a slide, so all these slides are available on the Path Presenter library. All you need to do is go and import from the library and put them into your presentation. And if you don't like a slide in the Path Presenter library, you can just upload if you have your own digital slides, you can upload the same digital slides into your presentation. There is an option to, when you upload a digital slide, it will ask you like, do you want to upload it to the library? So if you upload it to the library, it will become public. But if you don't want to make it public, you just don't click on upload to the library, and the slide then just remains in your folder. So if you don't want to share it with people, you can still upload it into Path Presenter, and it just stays in your folder actually. But now in this, so we were talking about lichenoid actinic keratosis. So again, here you are going to see this is a single lesion, has this lichenoid infiltrate, but now when you look at the basal layer, there is atypia in the basal layer actually. So when you start seeing atypia in the basal layer, even some mitosis, scattered mitosis, then your diagnosis is not going to be benign lichenoid keratosis, but a lichenoid actinic keratosis actually. So this one has some atypia in the basal layer, but it is not full thickness atypia actually. Again, has the lichenoid infiltrate. So this is a variant of actinic keratosis that is known as lichenoid actinic keratosis. And always they tend to have parakeratosis on the top, because most cases of like actinic keratosis are going to show you parakeratosis on the top. So there's parakeratosis on the top, a lichenoid infiltrate, and basal layer atypia. And then to move from one slide to the next, you're only going to you can either use these buttons here, or you can just use the keyboard. So on the keyboard, if you use the left and the right key, you can just move on to the next slide actually. So right now I'm using the keyboard, the left and the right key, to move through the presentation. So the next differential diagnosis is regressing lentigo maligna. So again, you see the lichenoid infiltrate here, but then this one tends to have admixed atypical melanocytes within the infiltrate, and many times you have to do a melan A to look for the melanocytes. But again, like what the mind doesn't know, the eyes are not going to see. So if you see a lichenoid infiltrate, a single lesion, always you have to think of, am I looking at a lentigo maligna which is regressing because of the lichenoid infiltrate? And we see these cases in meetings actually. So you have to be sure that you don't end up with a case that is going to be shown in a meeting, that this pathologist signed this case out as a lichenoid actinic keratosis or benign lichenoid keratosis and missed a regressing lentigo maligna. So these cases tend to end up in meetings. So always think about it. If you think about it, then you're going to be careful, look at the dermal epidermal junction, and you're going to find some areas that have some melanocytic nest, and then you do the melan A, and you're going to not miss a lentigo maligna that is regressing. So you have to always think about it when you see a lichenoid infiltrate. Not every case of lichenoid infiltrate is going to be a regressing melanoma, but 1 in 1,000 cases is going to be a regressing melanoma. So you have to then just think about it and rule it out actually. So now if you have a lot of eosinophils, what is your differential diagnosis? So if it is a single lesion, again your main differential diagnosis is lichen planus like keratosis actually. But if it is multiple lesions, then you start thinking of a lichenoid drug eruption. And the other differential diagnosis that we already saw was the lichenoid graft versus host disease. So that can also have some eosinophils actually. So in a lichenoid drug eruption, clinically it tends to resemble lichen planus. However, the lesions are much larger, and they do not typically show the Wickham stripe, those white areas that you saw in the clinical features of lichen planus. And these favor the trunk and extremities, and usually the oral cavity is not involved actually. Although there are some drugs that can cause oral cavity involvement, but most cases of lichenoid drug eruption are not going to have mucosal involvement. So let's look at a slide now. And one thing, like the latency period between the onset of the eruption can be years actually. So it is not like when you go back and take the history, you might get the history that the patient took a drug recently actually. It could even be months or years. And the common causes are captopril, propranolol, lithium, spironolactone, and the diuretics. So here's a slide. Again, low power, it almost looks like lichen planus actually. So if you look at it, it almost looks like lichen planus. You have the hyperkeratosis on the top, you have the wedge-shaped hypergranulosis, you have the lichenoid infiltrate, and some dyskeratotic cells. But like I said, whenever you see this, you go high power and then you just walk through, just scan the entire dermal epidermal junction. So in this one, if you start looking at it at high power, you're going to see all this eosinophils actually. So whenever you see eosinophils 1, 2, 3, then you don't call it lichen planus, you say lichenoid dermatitis, suggestive of a lichenoid drug eruption because of the presence of eosinophils. But you have to just go high power and then just scan the slide. So you go at the dermal epidermal junction and then you just scan the slide, and then you can differentiate between lichen planus and a lichenoid drug eruption. If it is now, so that was all the dense inflammation. So if it is now moderate to dense inflammation and you don't have any if you have the parakeratosis. So if you have the parakeratosis, so we were talking all the cases about no parakeratosis. If you have the parakeratosis and you have eosinophils, we still have the same differential that this is a lichenoid drug eruption. But if you don't have if you don't have the eosinophils, look at the infiltrate. What is the other cell type that you're seeing within the infiltrate? So if you see any admixed plasma cells, what is your differential diagnosis? Now, if you see lichenoid infiltrate with admixed plasma cells, and if you have this mixed vacuolar and lichenoid, and you have the elongated rete ridges and some endothelial swelling, you are going to think of secondary syphilis actually. And if you have this effaced rete, mild diffuse spongiosis, and flattened keratinocytes, you're going to think of Zuhn's balanitis. So we're going to look at both slides, but whenever you see plasma cells, think secondary syphilis once again actually. So syphilis tends to present with symmetrical, non-pruritic, copper-colored discrete macules and papules that involves the palms and the soles. Here's another slide of syphilis that is involving the sole actually. So when you look at a slide, again you have a very dense lichenoid infiltrate here. But now if you go high power, what do we see here actually? So when you go high power, you are going to see a lot of plasma cells actually. So whenever you see all these plasma cells, you tend to see a lot of plasma cells. So lichenoid infiltrate with a lot of plasma cells think syphilis actually. And then you do a spirochete stain. So here is an example of a small plasma cell. So in path presenter, the other cool feature is, like, if you even don't have a digital slide, this is a static image that we took of a plasma cell. You can actually now zoom into the static image actually. So even in a static image in path presenter, if you're using the platform, you can zoom into the static image and highlight the point actually. And when you see a plasma cell, you're going to do the spirochete stain and you're going to see the spirochetes, and then you confirm your diagnosis of secondary syphilis actually. In Zuhn's balanitis, clinically they present with this glistening red hemorrhagic patch on the penis. And when you look at the slide, again you see the dense lichenoid infiltrate, but now the epidermis, you have lost the rete ridges. And then when you go high power, you're going to see a lot of plasma cells. So it is almost like a plasma cell party going on here actually. So there's a huge collection of plasma cells that you see at the dermal epidermal junction. And then you see this atrophic epidermis, so you're going to think of Zuhn's balanitis. And if the clinician is saying rule out Zuhn's balanitis, these are the features that you want to look for actually. So now we'll move on to the mild to moderate inflammation. So we finished off moderate to dense inflammation, then we move to mild to moderate inflammation. So if you have mild to moderate inflammation, what do? You think, is it focal or is it more generalized? So is it like a focal lesion or they are more generalized lesions? So if it is a focal lesion, diagnosis, either it is lichen nididus or it is porokeratosis. So what is the clinical features of lichen nididus? So these present in children and young adults as these minute pinhead size flat top papules on the arms, chest, abdomen and genitalia. Here's another example where you can see that you see this pinhead papules both on the genitalia as well as on the arms actually. Histologically, very classically, it is described as the ball and claw pattern actually. So this is a very nice example of a ball and claw pattern. So what do you mean? So this is the ball of inflammation that you see here, which is composed of lymphocytes and histiocytes, and these are the claws. So the rete ridges, they are hugging the ball of lymphocytes and histiocytes on both sides like a claw, and this is usually limited to 1 or 2 rete ridges. So in lichen nididus, the inflammation is limited to between 1 or 2 rete ridges. The rete ridges, they act like the claws, and this is the ball, and the ball is composed of lymphocytes and histiocytes. So if you see this, then your diagnosis is lichen nididus. For porokeratosis, these tend to present in younger kids as linear keratotic papules and plaques with a raised edge along these Blaschko lines, usually on the extremities. When you look at a slide, where the classic feature in porokeratosis is this cornoid lamella. So you have this cornoid lamella here and this cornoid lamella. So what is a cornoid lamella? So cornoid lamella is columns of parakeratosis. So these are columns of parakeratosis that you see here. And like I remember when I was a trainee at MD Anderson, Dr. Rapini used to always say that this is like a train leaving the station actually. So this is the train moving here and this is the cloud of that over the train actually. So the train is moving in this direction and this is the cloud that you see over the train actually. And that is a good metaphor to remember actually. And when you look at this column of parakeratosis, you go high power, in the epidermis, they tend to show some dyskeratotic cells. So you'll see some dyskeratotic cells just below the column of parakeratosis. And these tend to be like on both sides. So you'll see one column here and you're going to see another column on the other side actually. So there's another column here. So this is the column of parakeratosis, and in the epidermis, you're going to see some dyskeratotic keratinocytes. So this is a nice column of parakeratosis that you see in porokeratosis.
So is there any other condition where you see the similar like cornoid lamella?
No, that is very classic for porokeratosis. The cornoid lamella is very, very classic for porokeratosis actually. So now if you have the mild to moderate inflammation, but the lesions are more generalized. So in the localized lesions, it is lichen nididus or porokeratosis. But now if you have more generalized lesions, then you are going to think of other differential diagnoses. So what are the other differential diagnoses? So for the first thing that you want to look for is, I have mild inflammation. Is there any pigment incontinence in the dermis actually? So whenever you see a mild lichenoid infiltrate with pigment incontinence in the dermis, your differential diagnosis, is it PIPA? Is it erythema dyschromicum perstans, or which is also known as ashy dermatosis, or is it amyloidosis? So in what do you see in post-inflammatory pigment alteration? So these are usually resolving lesions. So the patient might have some sort of an eczematous process, but now it has resolved actually. or the patient had some sort of a psoriatic lesion. So any inflammatory process that is resolved can end up as post-inflammatory pigment alteration. Like the name suggests, post-inflammatory. So there was an inflammatory condition going on, now it is resolved, so you're left with some pigmentation. So this is an example of a post-inflammatory pigment alteration. Histology is very subtle, you don't see much. All you're going to see is a very mild lichenoid infiltrate at the dermal epidermal junction, but the characteristic feature is this pigment incontinence that you see here actually. So very mild lichenoid infiltrate, but very characteristically you see all this pigment that is scattered. So you have melanin pigment here, that is scattered in the dermis. So if you see pigment incontinence in the dermis with some lichenoid infiltrate, like I said, your main differential diagnosis is it pipa, is it ashidermatosis, or is it lichen amyloidosis? So this is an example of post-inflammatory pigment alteration. If you're thinking of lichen amyloidosis, these can be two types. One is the macular and one is the lichenoid. In the lichenoid amyloidosis, very classically presents on the lower legs, and you see this discrete brown papules, typically near the shins actually. And the histology is very, very classic. So again, like low power, you're going to see some pigment incontinence. So when you see pigment incontinence, think amyloidosis, because if you don't think about it, you're going to miss it actually. So if you see pigment incontinence, you think of amyloidosis. And when you think of amyloidosis, you go high power and you scan the dermal epidermal junction. And if you look at it high power, then you're going to see this very classic pink hyaline deposition at the dermal epidermal junction. And this is amyloidosis. You can highlight it with Congo red. And because this is keratin derived amyloid, because this is derived from the keratin degeneration, you can also do a CK903. So you can use the CK903, which is a keratin immunohistochemical marker that is going to highlight the keratin derived amyloid. So whenever you see this pigment incontinence, think amyloid, go high power, scan the dermal epidermal junction and look for this pink hyaline deposits. If you see them, then your diagnosis is lichen amyloidosis actually. The next is in erythema dyschromicum perstans, which is also known as ashidermatosis. These tend to present like this bilateral symmetrical gray macules on the trunks and proximal extremities. Very common in people who come from South America actually, or Asia. So in the brown skin, this is a very common lesion. So they tend to present with this gray macules. And some people consider this as burnt out lichen planus. So histologically, like as the name suggests, like if it is a burnt out lichen planus, all the features of lichen planus are gone. So all you see is a very mild lichenoid infiltrate, but very characteristically a lot of pigment incontinence in the dermis. So you see all this pigment incontinence in the dermis in ashidermatosis, a very common condition that you're going to see in your practice. So we see one every week actually. So it is going to be one of the common things that you're going to see. So in histologically, you might see a mild lichenoid infiltrate, some vacuolar degeneration at the dermal epidermal junction, but the main characteristic feature is this pigment incontinence and the dermal epidermal junction. So you can see the pigment incontinence at the dermal epidermal junction. So now that was with pigment incontinence. So now if you see a mild to moderate inflammation with epidermotropism, so like what is epidermotropism is when lymphocytes are going into the epidermis, you think of mycosis fungoides. So mycosis fungoides tends to present in elderly men with patches and plaques and less commonly tumors, and they are more commonly on the non-sun exposed areas. Histologically, again, you see a lichenoid infiltrate. But now what is the difference what is different about this lichenoid infiltrate? There's a lot of lymphocytic exocytosis. So you see a lot of lymphocytes going into the epidermis actually. So you have the infiltrate, but now you have these large lymphocytes with some atypia, even some like convolution, like cerebral convolution that you are seeing in the epidermis. So a large number of lymphocytes going into the epidermis. So these are all lymphocytes that are going into the epidermis, and you see them at the dermal epidermal junction. So if you see a lichenoid infiltrate with a lot of lymphocytic exocytosis, you think of mycosis fungoides actually. And this is a nice example of, see all these lymphocytes that have this hyperchromatic nuclei. They are even like lining up the dermal epidermal junction, and they're going into the epidermis. So once you think of mycosis fungoides, then you're going to do your stains. So you do the CD3, 4, 7, 8, and a CD20. And you're going to see a predominance of CD3 and CD4 cells. In regular mycosis fungoides, there's going to be increased CD4, CD8 ratio, and there's going to be some loss of CD7 actually. So if you see all those features, then you can say that this is compatible with mycosis fungoides actually. Now, if you see if you see a mild to moderate inflammation, but there is a lot of purpura. So with purpura, you mean you see a lot of red cell extravasation. Then you're thinking of a lichenoid purpura actually. So clinically, these tend to present as this discrete, confluent, golden, purple, or brown macules, occasionally with purpura, and more common on the lower extremities. So when you look at a slide, you see this dense lichenoid infiltrate, but even on low power, like even if I don't go high power, you see there's a lot of red cell extravasation actually. So when you start seeing the red cell extravasation, you think of lichenoid purpura, and then you go high power, you can see the red cell extravasation very nicely. So again, a lichenoid infiltrate at the dermal epidermal junction composed of lymphocytes and histiocytes, but with a lot of red cell extravasation. Then the diagnosis is lichen aureus. Remember, there is always clinico-pathological correlation. So you're always going to go back and look at what the clinician was thinking actually. So if it was a single lesion, the clinician is thinking of some sort of a purpuric lesion, and you see this lichenoid infiltrate, then your diagnosis is going to be lichenoid purpura, or the other name is lichen aureus. If you see mild to moderate inflammation, which is with sclerosis, then you're thinking of lichen sclerosis. So lichen sclerosis tend to present as this cutaneous or mucosal process, and then you have this patches or plaques that have some follicular plugging, but they tend to have this whitish or discolored area actually, and they often have a violaceous or erythematous rim. When you look at the histology, you again see the lichenoid infiltrate, but now the lichenoid infiltrate is not hugging the dermal epidermal junction. So, and very classically, you're going to see the sclerosis. So this is the sclerosis part that comes, the lichen sclerosis. So what you see is atrophy of the epidermis, and then very nice sclerosis, or like a very pinkish hyaline areas that are very smooth looking at the dermal epidermal junction. And then this lichenoid infiltrate tends to be pushed down by the sclerosis. So when lichen sclerosis starts, this inflammation is quite high, but as the lesion progresses, the sclerosis tends to push the inflammation below the sclerosis. So you tend to see this inflammation that is below the sclerosis. Many times in lichen sclerosis, you might not even see the inflammation. All you're going to see is this very dense sclerosis that is at the dermal epidermal junction. And when the sclerosis tends to involve the lower part of the epidermis, then you call it morphea. So the similar changes, if you see it in the lower part of the dermis, it is morphea. And many times lichen sclerosis and morphea can coexist because they are the same disease process actually. So if it is just limited to the papillary dermis, you call it lichen sclerosis. If it is involving the deeper part of the dermis, it could be lichen sclerosis / morphea. But again, they have this lichenoid infiltrate at the dermal epidermal junction. Now, we talked about the mild to moderate. So the last category was if you have a lichenoid infiltrate with deep involvement. So if you have deep involvement, and if it is a linear lesion, then you are going to think of lichen striatus. So lichen striatus tends to present with this linear lesions mostly on the extremities. So these are self-limited eruption, common in females and children. They are unilateral linear eruptions of erythematous to skin-colored scaly papules along the Blaschko lines. And when you go high power, so the histology will depend on when it was biopsied. So early lesions tend to show the infiltrate very close to the dermal epidermal junction. But as the lesion progresses, the inflammation is like lichenoid, superficial perivascular, but very classically also having a deep involvement. And this slide doesn't have dyskeratotic cells, but many cases of lichen striatus will have mild spongiotic changes in the epidermis, some dyskeratotic cells in the epidermis, a lichenoid infiltrate with superficial and deep involvement. So, and the deep involvement tends to very classically involve the eccrine structure. So you can see that the inflammation is around the eccrine structure. So if you see something that is involving the eccrine structures, clinically is presenting as a linear lesion, your differential diagnosis is going to be lichen striatus. Again, in this one, I've used the tool for annotation. So when you click on the annotation, see, I have marked the pericrine inflammation. So you can actually use this tool to mark the annotations. The other way you can show these annotations is you can use the up and down keyboard on your mouse. So like if you use the up and down keyboard on your mouse, so let's go back. And then when I come back to the slide, I can actually use the up and down keyboard on the mouse to actually zoom into the annotation. So, and then when I bring my mouse, it will show what you want to show to the audience. So this is another way to show specific features on the slide actually. So then we move on to with generalized involvement more, but not linear lesions. So when you have linear lesions, you are going to think of lichen striatus. But now if it is more generalized involvement with deep lichenoid, with deep involvement and more generalized involvement on the skin, then you are either going to think of connective tissue disease or drug eruption. So in connective tissue disease, they tend to have more common in women in the 3rd to the 5th decade of life, and you have this atrophic, hypopigmented, and scattered patches. Histologically, we already saw one case, and again you see the lichenoid infiltrate. But like I said, whenever you see a lot of perifollicular and perivascular involvement, you're going to think of connective tissue disease. So if you see a lichenoid infiltrate, you see the hypergranulosis and everything, but now this is involving the hair follicle and also involving the deeper part of the dermis. So if you see this, then you're going to think of a connective tissue disease. So then you do your mucin stain, you're going to find that the mucin is positive in the dermis. And you can also look up the clinical history, whether the clinician has done some serology. So the AN is going to be positive, and if immunofluorescence is done, you're going to see a full house at the dermal epidermal junction. The last is the drug eruption. We already saw the lichenoid drug eruption, but this can look like very much like lichen planus, but they tend to be more photo distributed. So they may be involving the photo distribution of the skin. So but when you look at this biopsy, I didn't put a picture, a slide here, but you're going to see the eosinophils in the dermis. So whenever thinking of lichenoid drug eruption, you can have a lichenoid inflammation with superficial and deep with presence of eosinophils. So whenever you see eosinophils, you think of a lichenoid drug eruption. So the take-home message is, in a lichenoid inflammation, the key action is happening at the dermal epidermal junction. And when you're looking at main action happening at the dermal epidermal junction, you always have to think of lichen planus like keratosis, and then you look for eosinophils in the lichenoid drug eruption. And then you go on to the other features that we talked about. Does it have deep involvement? Is there any pigment incontinence? Is there any sclerosis? And then you can move, actually go through all the other differential diagnosis of a lichenoid reaction pattern. Thank you. Any questions?
So, but you will need to have clinical correlation, right? Suppose you are saying lichen amyloidosis. So basically that the dermatologist has to give you some differential, right? Otherwise, just,
for lichen amyloid, specifically for lichen amyloidosis, many times we don't get the the differential. You always have to think of it. So whenever you see pigment incontinence in the dermis, you always have to think of lichen amyloidosis, because once you think about it, you're going to go high power. And like you said, it was very easy to see, but you have to just go high power and look at the dermal epidermal junction to look for the amyloid deposition near the papillary dermis actually. Like for the other ones, lichen planus, like keratosis, you might still get some history, but lichen amyloidosis, most of the times you don't get any history actually. It always comes as some sort of a pigmented disorder of the skin actually.
So you can still do Congo red?
You can still do Congo red. You can do a PAS stain. It will highlight with both Congo red and the PAS stain. And like I said, because this is a keratin-derived amyloid, you can also do a CK903, which is a keratin immunohistochemistry marker, and it will still highlight the amyloid. But this, you can use this path presenter, like it is a free tool to use. Just go into path presenter, import your PowerPoint. There are like 6,000 slides on the cloud right now, which you can just use for your presentations. I showed you how to annotate the slides, how to put them in your presentation, and you can just do this from anywhere, anytime actually. So I think it makes pathology presentations much more interactive and much more useful. If you don't want to import a PowerPoint, you can just import 10 slides of certain entities and then use that for your teaching. Or if you're like self-learning, when you're reading a book, you can just open a path presenter, search library, put in the diagnosis. So you're reading about, say, prostate today actually. So you just click whatever diagnosis you are there, prostatic adenocarcinoma. So search library, put in the diagnosis, prostate adenocarcinoma. It will pull out like 15 cases actually. And then you can look at the cases while reading. So it makes it a good correlation for your reading actually.
But you are saying that, sorry.
Sorry, I have just one more question. even if you have all the features that you mentioned for mycosis fungoides, would you always call it compatible with, or?
Yeah, we always call it compatible with, because you have to remember many drugs like phenytoin can actually induce some lesions that are very, very similar to mycosis fungoides, even both clinically and histologically actually. So you always say compatible with, because the patient should have a long history of the disease, because mycosis fungoides doesn't happen overnight actually, but if it is drug induced, it is going to happen very quickly actually. So you always say compatible with, because you cannot with 100%, even if it has a gene clonal rearrangement with T cell, it still can be drug induced actually. So you always have to say compatible with. So you might have all the immunohistochemistry that is compatible. You might even have a gene cell rearrangement which is saying clonal population, but it still could be drug induced. So clinico-pathological correlation is very important to make the diagnosis of mycosis fungoides.
So you say that right now when we have all this coming to past presenter, so you have all the slides available, but there is at present there is no description of the slides, right? But,
right now there is no description of the slides.
But you say that soon there will be a connection to the.
Yeah, there is going to be a connection to this. So we are building another platform which is called Widex, which is completely content based actually. So there's a lot of content on that. So for every diagnosis, there's a lot of information about the diagnosis. So like multiple authors all across the country, like all the top-notch authors are actually writing content for Widex right now actually. But because writing content takes a longer time, so that is still taking time. So once we have all the content on Widex, which is wiydx.com, what is your diagnosis? You will link both Path Presenter and Widex. So like you can look at the slides here, use this platform for presentation, but for self-learning, if you want to find information about a specific diagnosis, the connection is going to be to Widex, where you will get all the information about that specific diagnosis. So hopefully this will make a complete platform for learning, sharing, teaching pathology that you can use from anywhere or any place in the world actually.
Yeah, this is really cool actually to integrate a digital slide into a PowerPoint.
Yeah, and it's very easy. Like it takes a minute. It just takes a minute to integrate like the whole thing, and then move the slides around and make the presentation actually.
And it makes the presentation much more interactive, and you can see a real slide, not a. And we can use it for actually, tumor boards, right? If we can scan our slides, so you don't have to take 100 pictures.
Yeah.
We just need a scanner.
Right.
Thank you very much for your attention.
Thank you. Thanks a lot.
Thank you.
Did it work well?
Smooth, yeah.
It worked well.
And then we got